The topic for this lecture is cardiovascular pathophysiology. What we'll do in this part of the lecture is we'll talk about the pathophysiology of atherosclerosis, address hyperlipidemia and how that actually can contribute to cardiovascular pathologies. We'll take a look at ischemia and infarct and how that leads to it actually is cardiovascular pathophysiology. And then it's important that we differentiate between stable and unstable angina and between non-ST elevation MI and ST elevation MI. And I do expect that you'll be able to make that differentiation in terms of the pathophysiology and the effect on circulation and overall health. So let's start at least a little bit by talking about myocardial cells and why they're so special. I know it's hard for you to believe that I'm actually saying that myocardial cells are special instead of kidneys, but they actually are. One of the things to remember is that myocardial cells have a single nucleus. Now this is different because skeletal muscles have multiple nuclei. In addition, myocardial cells have the ability to transmit action potentials, and this is necessary for the muscle to contract. So that whole thing we talked about, depolarization, repolarization, membranes, the potassium, the sodium, the calcium, and even magnesium, and that sodium, potassium ATPase pump is very important. Myocardial cells also just have an incredible ability to get what they need. They can access additional ions, especially potassium, sodium, calcium, and magnesium as needed. Now, because the heart can't stop, these myocardial cells have a constant need for ATP. The end result of that, as you might remember from the pretest, is that myocardial cells have a higher number of mitochondria than other cells. The last thing that we think about when we think about how special these cells are is that we have myofibrils. So these are the fibrils of the muscle. And within each sarcomere, there are actually these bands of myofibrils. And this is the basic unit of the striated muscle. These muscles are made up of myosin, actin, troponin, and these make cross bridges. Myosin has are the very thick bands of myofibrils, and this is where you get a lot of ATPase activity. Actin are the thinner fibrils within that muscle. Troponin is a protein, and specifically it is a relaxing protein, and we know that we use that as a biomarker. Now you should remember that there are a couple of different types of troponin. The two most commonly recognized are troponin T and troponin I. Troponin I is the one that we are especially interested in when we talk about myocardial injury. And so then we have these cross bridges for relaxation and contraction. So what happens in that process then is the thin actin myofibrils slide over the thick myosin fibrils in order to relax and contract. Now we know that one of our biggest concerns in cardiovascular pathophysiology is ischemia. But we also know that the body has a way of handling that, and that is through the development of collateral circulation. Recall that in order for the heart muscle to be circulated, blood has to flow through the coronary arteries. So if those coronary arteries become narrowed, whether it's from atherosclerosis, from spasm, or because they are being compressed by a very large heart muscle, over time our physiologic response to our adaptive physiologic response to a pathologic process is to develop collateral circulation. The primary reason or the stimulus for developing collateral circulation is shear stress. And that shear stress is from increased blood flow velocity near an occluded or a narrowed area. So that concept of shear becomes very, very important when we think about why we would need to develop collateral circulation. Because remember, collateral circulation is essentially to bypass a narrowed or an occluded area. So this arteriogenesis and the angiogenesis, the development of this collateral circulation, is going to develop proximal to the narrowed area. So in that angiogenesis, we develop new vessels, the purpose of which is to overcome the resistance and the velocity effects of that narrowed area. So then so if we summarize that, we have shear, which we know is important. That's a very important initial step in that. That shear, or that shear stress from the velocity near that velocity and resistance, stimulates growth factors and cytokines. Now, what kind of cytokines would these be? Correct. Pro-inflammatory cytokines. Because of the pro-inflammatory cytokines and to a lesser extent, but still those growth factors that are stimulated by shear, there is monocyte attractive protein as well as vascular endothelial growth factor being stimulated and developed. So as a result of these changes, there's going to be a change in the lumen of the vessel. So when we think about an ischemic process, we are thinking about the intimal layer. We're thinking about what's happening inside that vessel. Because remember, the coronary arteries are made up of three layers. The intima, which is your endothelial layer, which is closest to the circulating blood. The media, which is the muscular layer, and the adventitia, which is the outer layer of the vessel. So when we think about coronary artery disease, we have to think about atherosclerosis. Now, coronary artery disease by itself is not automatically ischemic or infarcting. However, the potential is there, and that's what we have to remember and we have to recognize. So we know that coronary artery disease is vessel disease, and it is very heavily dependent on the inflammatory process. Now, this inflammatory process is infected by innate as well as adaptive immunity, and that innate part is our standard inflammatory process that we've already talked about. Two other pieces that are important and also play into risk factors are elevated plasma cholesterol and dyslipidemia. Elevated plasma cholesterol, especially low-density lipoproteins and other dyslipidemias, help in forming the basis for the inflammatory process. So what happens in this process is the plaques form within that arterial wall, that arterial lining that may remain stable, become unstable, can break away, can occlude the vessel. And of course, the danger of these plaques is they can and often do continue to grow. And these plaques are filled with cholesterol and other products that, should the plaques rupture, all of those products that are in this plaque become released to the circulation. And again, this is happening in the intimal layer of the vessel. So what happens is you begin with an endothelial injury. That endothelial injury leads to the inflammatory process. That means the monocytes have been stimulated. With that, as mentioned previously, you have the release of pro-inflammatory cytokines, which then stimulate the development of vascular adhesion molecules. With those additional vascular adhesion molecules, macrophages are going to release additional enzymes, oxygen-free radicals, and develop then a fatty streak. That fatty streak is a dyslipidemia streak. With that fatty streak, with those dyslipidemias, there are more oxygen radicals, and now you're building this fibrous plaque. So this fibrous plaque develops an atheroma. this fibrous cap has an encapsulated, is encapsulated with a core. So you've got a cap around a core. And as long as this atheroma, which is an encapsulated core with a fibrous cap, as long as that atheroma is intact, it narrows the lumen, but the contents are contained. Now, what's actually in that and what predominantly is in that core is important. A stable atheroma has more collagen within that core. An unstable plaque have more macrophages. And so what happens then, and the concern that we have, is that fibrous cap begins to thin. So when that cap of the atheroma becomes thinner, the risk for rupture is much, much greater. And the risk of rupture is greater when there are additional growth factors. Remember the shear stresses that we talked about, as well as ongoing inflammation and that ongoing inflammatory process. So what happens then is as that fibrous cap gets thinner and thinner, the plaque is at risk to rupture. When that plaque ruptures then and releases everything into the circulation, that stimulates the clotting cascade and therefore thrombus formation within the lumen itself. So when the plaque ruptures, you're going to have a stimulation of both the intrinsic as well as the extrinsic pathway. Because when that plaque ruptures, what's the first thing that's going to be activated? Platelets. So those platelets become activated, and the tissue thromboplastin is then going from the endothelium is going to stimulate the extrinsic pathway activation. In that extrinsic pathway is activated, there will be the stimulation of fibrinogen, and remember that facilitates the clumping of those platelets. At the same time, we stimulate the intrinsic pathway. So when platelets are activated, we have the release of the thromboxane as well as platelet factors. That then stimulates the intrinsic pathways. The intrinsic and the extrinsic comes together. The platelets clump. That leads to the formation of thrombin, which goes to fibrin, which goes to the clot itself. Now, where the clot is and the size of the clot is going to matter. So very small clots may pass unknown. However, if it's a very large clot, it's going to become larged within a coronary vessel, and so that could cause an infarct. It could go to the lungs, and it could cause a pulmonary embolus, or it can go to the brain, and it could cause a cerebrovascular attack. And so all of these steps, this whole thing about this atheroma, and whether it's stable with more collagen in it, or whether it's unstable with more macrophage activity, becomes very, very important as we think about how atherosclerosis is extremely dangerous. Whoops, sorry, let me go back to that. Didn't mean to go through that quite so quickly. So if we look at this then, and we'll talk about foam cells, remember, are part of our fatty streak, and I like the way this goes through decades. Now, even though they talk about years and years and years, because atherosclerosis is a chronic process. You don't go to bed one night and not have atherosclerosis, and the next morning you have it. So it is developing over time. So you have the foam cells. There's that fatty streak that we talked about. And you can see what's happening here along the bottom. You can see the development right here. You can see that there is also, the lesion is getting bigger, and now you're developing the atheroma, the fibrous plaque, and remember this is the This is sort of a cap. Now, I think what's difficult when you look at what happens here is this is your muscular layer. So this is the media, and this layer here is all your intima. But this right here is still part of your intimal layer. But this one, it has ruptured. So this plaque is very fibrous and is, remember, that cap. So you have smooth muscle and collagen, and then with the rupture, you have thrombosis. And you can see where I got that if you play with this a little bit. Another way of looking at this is, once again, there's your media, there's your intima, and I think this one actually shows it just a little bit better. I kind of like this one a little bit better in that you can see that lipid core. Inside that lipid core, you have foam cells and you have inflammatory cells, those T lymphocytes, and you can see that tough fibrous cap. And the reason I like this one a little bit better is that it doesn't look as though the intima there's that core is actually separating the intima from the media. You can see that the intima is still there, and then you have this cap. The other thing that I think, once again, what triggers this plaque to rupture? What would trigger this pathology to go to the next step, that rupture step? We know that smoking is a major trigger of plaque rupture. Smoking itself, nicotine is a vasoconstrictor, and that can actually facilitate rupture. Ongoing elevated levels of cholesterol. It continues to build, and as this continues to build, you're going to be more likely to have problems with shear forces and shear stress. And again, the inflammatory response. So let's turn our attention then to I don't know why I did that. To dyslipidemias. So we have two major theories in coronary artery disease. One is the dyslipidemic or dyslipidemia theory, and the other is the inflammatory theory. And I think they're both very, very important because one is not mutually exclusive of the other. And as we think about treatment of coronary artery disease, and I know our goal here is not to talk about treatment, but if we talk a little bit about treatment, our treatment makes sense and we can see what the role is in terms of altering the pathology and the pathophysiology of coronary artery disease. But we have to think about dyslipidemias. With dyslipidemia, we have to think about adults as well as children because elevated lipids and changes in lipid metabolism occur at all ages. Now remember that first picture slide that had the first decade, second decade, third decade. What that's really showing us is that these atheromas, of which a huge part of that is dyslipidemia because it has a lipid core, develops as we age, and as we are growing up means as we are aging. So when we think about dyslipidemias, we're thinking about lipids, phospholipids, cholesterol, and triglycerides. So our lipoproteins are our lipid transport mechanism, and these are chylomicrons. And chylomicrons are the way triglycerides are essentially packaged. So when you look at a chylomicron, then you're looking at a hydrophobic core of triglycerides with cholesterol esters coating that hydrophobic core. And that cholesterol, I'm sorry, let me back up. The hydrophobic core is made up of triglycerides and cholesterol esters. And this core is coated with phospholipids, cholesterol, and apoproteins. When we look then at the lipoproteins, these lipid transporters, we know that we have very low density of lipoproteins, which are VLDL. We know those are bad actors. Triglycerides, which are also negative actors because they are pretty big molecules. Sometimes you will frequently see an elevated total cholesterol, and the main component of that total cholesterol would be the triglycerides. We also, in addition to VLDL, we have low-density proteins. The VLDL and LDL lipoproteins have a positive association with atherosclerosis and elevated overall cholesterol levels. And those are the negative lipoproteins. On the positive side, we have the high-density lipoproteins, and they function sort of as scavengers. We know that high-density lipoproteins have a negative association with atherosclerosis. So what that means is high levels of VLDL and LDL facilitate atherosclerosis. High levels of HDL, or high-density lipoproteins, discourage atherosclerosis, as well as the development of phospholipids. So let's take a second then, before we look at lipoprotein A, and talk about how, relate this to a little bit of what we do in treatment. So when you look at those anti-cholesterol drugs, for the most part, what they are trying to do is either decrease the absorption, the use, or the production of cholesterol, triglycerides, or LDL. Or they are trying to increase the production of HDL. So we're trying to decrease the absorption, use, and production of the negative lipoproteins and increase the use of the positive lipoproteins. Now, statins are the biggest drug that we usually use. They're usually our first-line treatment. And they do assist in the absorption, the use, and or the production of these lipoproteins. However, what's very interesting about statins is that they also have an anti-inflammatory effect, thereby helping stabilize plaque that is already there. Now, when we first started using statins, we didn't know about this anti-inflammatory effect. And so that's called we call that a pleiotropic effect. A pleiotropic effect is a positive, unintended effect that you may have from a medicine. So that was a great positive pleiotropic effect of statins. Not only does it have an anti-cholesterol action, but it also has an anti-inflammatory action. You may also have heard about a new drug, PCSK9. PCSK9 mimics a gene mutation that leads to a decrease in the LDL and therefore is cardioprotective. Now, this is a new drug that's out there, but I mention it because we've talked about genetics, and we've talked about genetics and the role of genetics in pathophysiology and the development of pathophysiology, but we're also using our understanding of genetics to expand how we treat disease processes. The last thing to talk about, or the final thing we'll talk about with dyslipidemia, is lipoprotein A, often manifested or displayed as Lp(a). Lipoprotein A is LDL plus apoprotein A, and this is a genetic factor. Now, lipoprotein A, this apoprotein A and this lipoprotein A, it is estimated that about 25% of the U.S. population have elevated levels of this lipoprotein A. We know that lipoprotein A is prothrombotic and thrombogenic. As a result, then, if you are one of those individuals in that 25% of the population that have this elevated level, you have an increased it's an individual risk factor for cardiovascular disease, stroke, restenosis of vein grafts, retinal thrombosis, all those pieces. So think of lipoprotein A as atherogenic. And we do know that this is a component of familial hypercholesterolemia. So when we look at that, because this is a genetic or a familial influence and variation on dyslipidemia, we would be looking for this variation in an individual who has early evidence of cardiovascular disease. So for a male, that would mean evidence of cardiovascular disease in their 20s to 30s for a woman, and usually their 30s to 40s. In addition, in our history, we would look for the history of a family history of premature cardiovascular disease. So those are some of the things. This is how we are able to use this information of our pathophysiology as we begin to think about what is going on with patients in terms of manifestations as we look at dyslipidemias and the important role that dyslipidemias play in the development of atherosclerosis, that plaque formation, and as a result then cardiovascular disease. Let's take these concepts then of atherosclerosis, dyslipidemia, and inflammation, and let's talk about myocardial ischemia. Now, myocardial ischemia can be both reversible and non-reversible, but very simply remember that myocardial ischemia is a classic mismatch of supply and demand. And when you have ischemic symptoms, or you have myocardial ischemia, you know that you have an inability of the coronary arteries to dilate enough to deliver the necessary oxygen to those myocardial cells. So the two variables you would want to always take a look at are oxygen delivery as well as oxygen carrying capacity. When we look at delivery, we're looking at the condition of the vessels. So again, vessels, we're thinking about the lumen of the vessel as well as the walls of the vessel, because the delivery can be because the vessel is occluded, atherosclerosis, that atheroma, or it could be because the vessel is spasming. Great example of coronary artery spasm is someone who takes cocaine. So if someone who is a cocaine abuser would present as the manifestation being unrelieved chest pain, when the spasm is relieved and you do a cardiac cath on them, their arteries look pretty good because it's not an atheroma problem. It's not an interior vessel diameter problem. It's because those walls spasmed and narrowed because of the spasm. The second thing second thing we think about in addition to delivery is capacity. So when we think about capacity, remember we talked about anemia. So if someone is anemic and they have a decreased amount of hemoglobin and they decrease their ability to carry red cells in those red bloods, that ability of those red blood cells to carry sufficient oxygen, you still have a mismatch of supply and demand. So when we think about ischemia then, if you think about an ischemic area or myocardial ischemia, generally what that can lead to then is a decrease in cardiac output because an ischemic muscle cannot do the work, and especially that left ventricle. You will see conduction abnormalities. Ischemic cells are more likely to display conduction abnormalities because of sodium, potassium, calcium, and also magnesium alterations because they aren't getting the necessary electrolytes. Along with ischemia, you would also see the development of anaerobic metabolism. Remember that the myocardial cells are very ATP dependent. Now the myocardial cells do have the ability to survive about 20-ish minutes until all of the ATP has depleted. But remember that they are undergoing anaerobic metabolism, and that is less efficient energy metabolism than if it was aerobic metabolism, and you are going to see the buildup of lactic acid. When we think about reversible myocardial ischemia, the classic of that is angina. Angina is transient and is reflective of an inadequate supply in time of demand. Now, Chest pain with activity or with stress is the demand. And so when you increase that demand, the individual is ischemic because supply doesn't meet that demand and they have chest pain. So as a result, you have to either remove the demand or increase the supply. That's the key. And that's what you do with myocardial ischemia. You either take the demand away or you have to increase that supply. So when we think about angina, we think about typical and atypical pain patterns, and we think about stable versus unstable. So a typical angina that is transient, if you remove the demand, if you take away the activity, if you take away the stressor, the chest pain goes away. An atypical pattern, you're seeing angina at rest. And so that would say, well, there's no demand there. Why is this patient having ischemic symptoms? The pain pattern is actually from that lactic acid, or it may be from stretching that ischemic myocardium. So let's think then about what happens if we don't increase this supply. So when we think about myocardial infarction, very broadly, we should be thinking also about acute coronary syndromes. And acute coronary syndromes include unstable angina as well as MI. Unstable angina is of concern because unstable angina means you have an increased frequency of the chest pain, or you have that atypical chest pattern where you're not really putting any demand on, but you're still getting chest pain. The concern with unstable angina is that those coronary arteries, or a coronary artery, is beginning to occlude, and they're no longer able to dilate or change in order to bring sufficient oxygen to the area. With myocardial infarction, we look at both ST elevation MI and non-ST elevation MI. So what happens with infarction? Well, you have plaque rupture and thrombus formation. Sounds simple, doesn't it? But remember that when that plaque ruptures, it stimulates the clotting cascade and the activation of platelets. When you activate those platelets, you have even more adhesion molecules and more adhesion and aggregation of those platelets. So once a plate ruptures and you stimulate that clotting cascade, you are going to continue to obstruct that vessel lumen, and you're going to continue to worsen the circulation distal to the obstruction. So as you think about what we do about that, what's our emergency treatment of acute chest pain? Aspirin. What does aspirin do? Decreases adhesion and aggregation of platelets. That's why we use it. Now, at the same time that this plaque is stimulating that clotting cascade and getting all the platelets all riled up into the same area, there's also the release of those vasoconstrictors, thromboxane and endothelin. So with the vasoconstrictor release, not only do you have a narrowing of the vessel because of the plaque rupture and that activity, you're going to have vasoconstriction that brings those vessel walls in, and it just makes the lumen smaller and smaller and smaller. Unstable angina indicates that there is a reversible occlusion with the return of perfusion. However, unstable angina is extremely unpredictable. But remember, with unstable angina, you haven't had plaque rupture. With an MI, you've had plaque rupture, and everything that is underneath that fibrous cap has been released into the vessel, all those microns, chylomicrons. And with an MI, you're unable to reverse, and you don't have a return of of that perfusion. As mentioned previously, myocardial infarction comes in two general categories, non-ST elevation and ST elevation. In general, the non-ST elevation means that the vessel has not occluded, but the ST elevation means the vessel has occluded, because that's what you see. ST elevation is an indication on an EKG tracing of occlusion. With the both non-STEMI, even though the vessel wasn't occluded, it has been narrowed, as well as the occluded vessel, you have, with MI, you have an extended loss of perfusion. With that extended loss of perfusion, the myocytes become necrotic in the area of the myocardium supplied by that specific coronary artery that's been affected. And we know that there's an issue because of cardiac troponin. And the cardiac troponin that we are interested in is troponin I. Now, even with non-ST elevation MI, as well as ST elevation MI, enzymes are increased. Those enzymes are increased without apparent reason, and troponin would be increased as well. So troponin I is a cellular biomarker that is released by those hypoperfused myocardial cells, and it's present in the circulation within 2 to 4 hours. Now, a single level of troponin is less useful than being able to trend those troponin, the level of troponin, because it will start to trend up, and then it begins to trend down over time as you restore perfusion. Remember that we are concerned about perfusion distal to the clot. So it's perfusion distal to the clot that is being decreased, and if your patient doesn't have that collateral circulation to take on the workload, then you have an ischemic area, and you have a poorly or non-perfused area. Now, we know that what we have to do, though, in order to keep those cells from dying and going and having complete cell death that we can't return from, is we have to reperfuse. However, reperfusion doesn't come without a cost, and this is called reperfusion injury. So we have to reperfuse to resuscitate the ischemic or the hypoxic areas of the myocardium. And remember that those myocytes can withstand either a severe or total ischemia for about 20 minutes at the most without death. However, you've got radicals and pH changes that are very damaging that are occurring. The other thing that happens as we begin to get reperfusion down into the area is that after blood flow is restored, while we have those radicals and pH changes that continue to contribute to additional cell death, we also have problems with calcium. Calcium activates calcium-dependent proteases, and that calcium is being released is also within those cells that are now being reproduced, and that's being restored. The longer the cells are ischemic, the greater the likelihood that the myocyte damage is going to lead to reperfusion injury. So that's why they keep saying time is muscle. Now, is reperfusion injury always lethal? No, it can be non-lethal or it may be lethal. What happens and whether or not it's lethal or not is however somewhat time dependent. That then leads us to another important concept when we think about infarct, and that's cardiac stunning. With cardiac stunning, and this is more likely to occur the longer the muscle is ischemic, is that there's an area around the ischemic area that can become necrotic. And as a result of that, there's a temporary loss of contractile function. So this can be a prolonged but reversible contraction dysfunction, and is sometimes one of the etiologies of an ischemic cardiomyopathy. So what happens in cardiac stunning is you have microvascular injury as well as endothelial injury that leads to irreversible cell damage and necrosis. So you might say this is the more lethal side of that reperfusion injury as well. And the size of the zone of injury matters. With that microvascular and endothelial damage, you have vasoconstriction, platelet aggravation, leukocyte activation, and an increase in those radical oxygen species. The longer the anaerobic metabolism has continued, the slower the recovery. So I hope I've been able to kind of give you a walkthrough of what happens here. So if we pull that all together with atherosclerosis through infarct, you have atherosclerosis. When that atherosclerotic plaque obstructs, there is decreased perfusion distal to the obstruction. We also know that we need to resuscitate ischemic areas. When we have that cell death, then we know that we need to perfuse that that area that's distal to the obstruction, and that obstruction is either because you've got an atheroma that is so big that it totally took up the wall of the lumen of the vessel, or more commonly, the fibrous cap became thinner and it released contents and you had a thrombus. With that cell death, we know that our goal is to reperfuse, and we need to perfuse. However, that can lead to reperfusion injury, and that cost of reperfusion injury is cardiac stunning. The zone of injury and the zone of cardiac stunning matters. The size matters and the length of time matters. Remember, with cardiac stunning, the area around that badly perfused area is less contractile, but we do have an opportunity to reverse and repair that if we can get oxygen to that area. So after the MI, the constellation is cardiac stunning, microvascular injury, and endothelial injury. You have vasoconstriction, platelet aggregation, leukocyte activation. The end result of this entire process is remodeling of that area that was not perfused, and then repair of that area. And that does take time, but it always leaves a scar, which is what we see on our EKG. So lots of information there. McCanson-Huther has some great pictures as well as very good explanations that I hope support the explanations provided in this lecture. If you have any questions, I'm here for you. Thank you.